Well, thank you very much for inviting me to this important meeting and to this topic. Obviously, I'm going to be talking about cancer clinical trials, but it could be applicable to other types of clinical trials. The initiative was done by ASCO, the American Society of Clinical Oncology, and the Friends for Cancer Research because they appreciated the fact that patients are being inappropriately eliminated from clinical trials because of issues which may not be clinically relevant or relevant to the endpoint of the study, just as we've discussed previously. While these studies were not done specifically for older patients, but because of older patients' comorbidity, it's particularly important for older patients because, as we've seen, they're underrepresented on clinical trials, and we have to increase that. The initiative from ASCO really was spurred on by the development of non-chemotherapy drugs, particularly the molecularly targeted drugs, with the realization that since we were going away from classical chemotherapy, we need to develop new criteria to put patients on clinical trial and to increase the number of patients participating on clinical trials for all the reasons we've mentioned, to make them broadly applicable and to make them more real world. So ASCO decided to, in the initial phase, to number a specialty criteria to look at. They looked at brain metastases, minimum age, HIV, and what I'm going to focus is organ dysfunction and prior and concurrent malignancies. There were multiple stakeholders, and each of these stakeholders participated in the development of these outcome and conclusions and recommendations. So the goal was to challenge past assumptions and practices like we've been discussing, create a new culture, and very importantly, only exclude patients where there's a true safety issue, change the perception and attitudes and practice of clinical trial eligibility, and expand the criteria and decrease exclusions to make them more broadly applicable. And of course, to implement these recommendations, and very importantly, to work with the FDA and pharma to see if we can implement these recommendations. So I'm just going to run through a few of them and then touch on organ dysfunction. A lot of patients with brain metastases are very well treated and controlled, and many of these patients have been automatically excluded. So we set up criteria for treated and stable brain metastases, not to exclude most of these patients from clinical trials. Obviously not a geriatric issue, but in terms of the thought process and the concept of broadening clinical trial eligibility to include adolescents on some adult clinical trials where the biology is felt to be similar. And of course, I could always extrapolate that to the other end of the spectrum to older patients. HIV is very important because HIV goes through the spectrum from young to old, and these patients should not be excluded from clinical trials. The main issue, the main problem in HIV patients on clinical trials is the use of antiretroviral therapy, which has a potential for a number of drug interactions, particularly with the oral molecularly target agents. The issue about organ dysfunction is particularly important because, as you can see, if you go by diagnosis, and these were all patients seen consecutively at the Kaiser Permanente group, where this data was available, that a large percentage of patients had creatinine clearances less than 60. And the creatinine clearance of 60 is the traditional criteria that people use in clinical trials to include or exclude patients from study, even if the drug that is being studied has no renal excretion. So therefore, these patients are excluded essentially unnecessarily. What's very interesting also, it's also by diagnosis, whereas the breast cancer population, which tends to be younger with less comorbidity, only about 20% of the patients had a abnormal creatinine clearance. At the other end of the scale, with bladder cancer, where the patients tend to be older with more comorbidity, almost 50% of the patients had abnormal creatinine clearances. So it was very important to see this kind of data to get an understanding of the type of patients we were excluding just based on creatinine clearance alone. So we set up a number of recommendations based on our analysis to try to increase the number of patients eligible for clinical trials. First thing we did was make sure that clinical trial eligibility should be based on creatinine clearance, not serum creatinines. And we felt that this should be liberalized to approximately 30 mils per minute, particularly when the drug or drugs involved in the study have no significant renal excretion. There are a number of established dose modifications that have already been, are in the literature. If the patient should develop renal insufficiency or start with renal insufficiency, to make an appropriate dose adjustment. In clinical trials that we've done in the cooperative groups, turns out that if this is done from the onset of the treatment, that patients can receive drugs safely without sacrificing efficacy by adjusting the dose to renal function. Hepatic function obviously is a little different. We have no Cockcroft-Gault equation, unfortunately, for hepatic function. I think we have to monitor these levels carefully, particularly serum bilirubin. And there are some published dose modifications. These are not age-related phenomenon like they would be more with renal function, but certainly small changes in hepatic function in drugs which are hepatically metabolized can lead to significant toxicity. The current eligibility projects ongoing to expand this currently include performance status, washout periods and concomitant medications, the issue about polypharmacy, prior therapies, test intervals, and lab reference ranges. A lot of these issues are particularly important for older patients who may not be able to make multiple visits for lab testing, and that alone may cause them not to participate in a clinical trial, with the burden on their families and the social burden of bringing them for frequent tests and appointments. So, as we all know, the overall clinical trial participation, and in particular for older patients, has been quite poor. And we've seen a number of examples where patients over the age of 70 years are underrepresented on clinical trials. The trials need to be designed so that they reflect the patients with the disease. And in medical oncology, the majority of patients we treat and the majority of the morbidity and mortality of cancer is in patients over the age of 70. All of us want to practice evidence-based oncology, and we can't do that in the older patient, even now, due to lack of that evidence. As I mentioned, they're the majority of patients and that of the majority of cancer mortality. And as we move away from traditional chemotherapy, that will force us to have new kinds of thinking in this area. And the clinical investigators need to design trials with their disease and with these issues in mind. As an outcome of the patients with organ dysfunction group that was set up by ASCO and the Friends of Cancer Research, just recently, the FDA published this guidance document, particularly for pharma, to make these recommendations to try to implement the recommendations of the organ dysfunction group and prior malignancy group to include more patients on clinical trials. I should note, I didn't have a slide on prior malignancies, but as was noted, patients over the age of 70, a very high proportion of them have had cancer previously, may have had radiation previously, may have had chemotherapy previously, and this should not be an exclusionary criteria for clinical trials. Even patients with indolent concurrent malignancies should be considered, such as early stage low-grade prostate cancer or a low-grade lymphoproliferative disorder, which may not affect the patient's overall prognosis and will not interfere with—
Just giving you your 2-minute warning.
Okay, great.
Thanks.
Thank you. So basically, that concludes the talk. I think the issues are, again, when these clinical trials are developed, think of the drugs which are being used, think of which are really important in terms of inclusion and exclusion criteria. If a drug is hepatically metabolized, there is no reason to have a rigid creatinine clearance determination to make patients eligible. And this alone could increase the ability of older patients to participate in clinical trials, as with the prior malignancy issue. So thanks very much for inviting me to this meeting. And again, thank you very much.